everyone. I'd like to start by acknowledging Mrs. LHIN and Summit Housing for their leadership role in having sponsored this for the last 5 years, and hopefully will continue that leadership role by continuing to host this summit. There are not a lot of these summits being held by LHINs, so I just wanted to acknowledge that and hope that you'll continue in that leadership role. And if you could then, in my Jamaican parlance, join me in bigging it up for this organization. Thank you. And for total disclosure, I'm on the board of Health Equity Ontario. So, so if Anna messes up, as a board member, you know how that is. Anyhow, my presentation won't be too long because Anna has a fair bit to say, and then leave some time for questions and answers. This is a picture of Ontario. And if you go, you can see who migrated into Ontario and how that picture has changed over time. The question that I ask when I look at this picture is when I go to Loblaws, I see a change in Loblaws. Loblaws now, I can go into Loblaws and get ackee. Yes. I can go into Loblaws and get jasmine rice, I can get basmati rice. Loblaws has changed its business plan. I'm not sure healthcare has yet changed its business plan to reflect those changes of who we are that are now in Ontario. When I came to Canada in the 60s, we all lived on Bathurst Street. Bathurst was the Caribbean area. Then as you made it, you moved to Thorncliffe Park. Then as you made it, you moved out to Malton. And then as you made it, you moved up to Oakville. Not to Oakville, to the top end of Mississauga, Brampton. And then as we moved in, white people moved out to Orridgeville and moved out, and then we followed. And so that's not an urban thing. That's happening all across GTA, all across urban centers. And that's what all healthcare will look like. So following on the data piece, I have another piece around equity that I don't hear a lot about, but is a piece that I am now advocating for. Decision makers in healthcare. For equity to really work and use this data, we need some changes at other levels in healthcare. So for me, decision makers in healthcare need to reflect the community. That for me means board members, senior staff, middle managers. We need different voices. Notice I don't say represent, I say reflect. We need diversity and equity at those tables of decision making. Advice. When we begin to pull people together to give input, are those communities and voices we're hearing from diverse as well? Because other than that, we're getting one-sided advice. When we look at who delivers care, who are they? Are we seeing in our healthcare systems the cleaners, the receptionists, those frontline diverse? But when we get along the professional lines, we don't see that diversity. And what are the feeder systems into those professions? So that at the end of the day, that chart that shows who we are coming in, who we are in receipt of care, we should see a similar chart when we line up our healthcare organizations, our healthcare employees, our healthcare boards, our healthcare senior staff. So I would just suggest that as we're moving forward with equity, we're looking at the patient side with the data. We need to now apply it to the decision-making side. And it's only when we get those two together that we will actually see equity being achieved. So I would encourage you as we do the planning at the next stage of equity, the leadership, to continue this leadership role, is to push that other leadership agenda, which is not an easy agenda to push. It's an uncomfortable agenda, and you will get backlash, but it is an important agenda that we have to do. I think equity is important, not because it is the political thing to do. I suspect, depending on how the election goes, is whether or not equity will remain on top or drop to the bottom. That has nothing to do with us in the room. Everybody in this room is a leader. We can now continue our own leadership role to push this agenda. And just before I pass over to Anna, there are different types of leadership in pushing forward equity and data collection. There is organizational leadership, like these two organizations have led this work for the last 5 years. There is a leadership from those of you who are employed within the system, and I know it's not always easy to push the equity agenda up if you don't have recipients at the top to take it, but you continue to do it. But there's also an emerging kind of leadership that is at play. So at the Toronto Central LHIN, we certainly pushed for data collection across the LHIN with some success, not a lot. Mrs. Arbor, I think, has had more success in picking it up and moving that agenda forward. So that has been good. But because we got frustrated, several of us, in that, what happened then is that we started to pick up other avenues of trying to advance this agenda. So we knew as a community that the child welfare system was taking Black and Indigenous kids at a disproportionate rate. We kept arguing about it, and people kept saying, there's no data. You know, this evidence-informed thing that we all say is a wonderful thing. It's also a cop-out in a number of areas. But then we finally found a star reporter who took on the agenda and did a survey, and it blew up. We should never have had to use the press to blow something like that up. Then we got organized, and we now have the Anti-Racism Directorate pushing an agenda that's going through legislation that is going to mandate certain forms of equity data collection. So it's coming from the other end. Health has not yet bought into that. Health tells me at the ministry that they are committed. I will wait for the next 2 years and see how that gets delivered. But a number of groups are also beginning to organize. So you have the Black Health Alliance, which I'm a part of. I'm going to help move the agenda. The Mount Sinai group we've worked on, move that agenda. I've worked with a number of Indigenous groups that are also organized to say, we're at the negative receiving end of care. I just came from Sudbury last weekend. They had the LGBTQ Rainbow Health Conference. Over 200 people came to that. And those groups, there's a South Asian group dealing with equity. We are beginning to connect together because we feel we also need the community side pushing for this equity, not just the data, but the use of the data to make a difference. Our goal is at the end, that change that we see about who we are, coming from different places onto this land, that our care system respond to them, delivering care to us in the same way. And our system was designed for the first wave. It's not yet designed for us. So I'll stop there. I did share the equity report that was accepted. HQO decided, moved on this. A group of us got together. I chaired that. The report was done. HQO accepted that report. The board embraced it, and it's now in the implementation stage. And I think HQO leadership in health equity will also spur movement in health equity along the way.
Really pleased to be a part of it and to represent Health Quality Ontario. I wanted to start by saying that I think we're extremely fortunate in Ontario to have a very solid foundation for tackling disparities. And this is due to the vision to leaders like Camille, who realize that health equity is local, it's regional, it's provincial, and beyond. And in order to make lasting change, we need lasting building blocks. We need to enable health equity in a way that not only could it be easier to promote, that it would be impossible to ignore. My organization itself came out of these building blocks, Health Quality Ontario, and I'll speak about some of the ways that we are trying to work with organizations like the ones represented in this room, like the two that are sponsoring this symposium, and how we can work together to continue to keep this at the top of the priority list, no matter who is in power in Ontario. So I want to just reflect on 3 pieces of legislation. Legislation has a role to play in this. It's not going to get us, it's not going to go the distance, but it's important to recognize what's available to us, what frameworks that we have to build on. And the first is the Excellent Care for All Act, which I think most of the time we think about as a vehicle to promote quality throughout the health system. And it can be sometimes easy to forget that quality through this legislation includes integrally equity. And that's part of the definition. And in the title of the legislation itself, that you can't have a high-quality health system unless excellent care is delivered to all. More recently, Camille spoke about the Anti-Racism Act, which enables the collection and management and use of race-based data, culture, socio-demographic data in Ontario in the public sector. It is true that we have some barriers in health, but I think it's really important to recognize Toronto Central LHIN, Mississauga Halton didn't wait for this legislation to get started. And so legislation has a role. It means it normalizes this kind of collection in the province. It means anybody should be able to take this up and should take this up. But it doesn't mean that we have to wait for these kind of frameworks to get going. And the last one is the Patients First Act, which clearly builds on the Excellent Care for All Act, where before we could say that this LHIN and all LHINs in Ontario had a responsibility to think about who was walking in the door for services. That's no longer sufficient, and this act talks about the accountability for population health. Who are we not serving, and who is accountable for making sure that we know who we're not serving, and that we do more to ensure that you're not just serving those who come through the door. So taken as a whole, this is a strong foundation. As I said, it's not sufficient, but it's an important foundation for the whole province. My organization, Health Quality Ontario, comes out of the Excellent Care for All Act. Again, this is about embedding quality in the health system. It's unique legislation throughout the world in terms of saying that quality is integral to health system service delivery, health care delivery, and that equity is integral to that definition. And there are 3 levers that were put in place for our organization, and I'll speak about each of these, but I just want to introduce them so that I can talk about how we are trying to embed equity in everything we do as the provincial advisor on quality. So the first is that we have a mandate to promote healthcare that's supported by best available evidence. And I'll talk about how do we embed equity in that role. The second is that we report to the people of Ontario how well the health system is performing. It's something that we've done for 10 years, now 11 years. And we also support organizations like the ones in this room in terms of promoting continuous quality improvement. And I'm going to speak about each of these functions in turn and how we are trying to not only embed equity in everything we do, but to support your organizations and how we can work together through these 3 levers we have, the levers that you have, to keep equity at the top of the agenda. So it's been nearly 20 years since the Institute of Medicine defined quality as having 6 dimensions, and equity was a part of it from the beginning. And it's been easy to think about each one of these dimensions, so safe, effective, patient-centered, efficient, timely, and equitable, in isolation. And we've had eras in healthcare policy, if you look over the past 2 decades since this was defined. You'd say we had the wait times era, which was all about timely care. You could say we had the SAFE era, which was about responding to how do we reduce preventable errors in our health system. You could say that some of the excitement, enthusiasm about patient-centered care and patient engagement could risk becoming its own silo. And one of the things we've tried to do as Health Quality Ontario in adopting this definition is that all 6 of them are important. They go together, and that we can't forget, for example, equity, patient-centeredness when we think about safety or timeliness. And we very consciously talked about quality improvement is all 6 working together. And part of talking about the comprehensiveness of this definition was that we needed to have a shared definition of what health equity was. Camille talked about the health equity roadmap, and this was to elevate health equity among those 6 dimensions. We couldn't ignore it. We couldn't just say we will stratify by equity dimensions no matter what we do. It's as important as those other 5. So we need to always be asking the question, who is not getting safe care? Who's not getting effective care, efficient care, patient-centered care? And that is what health equity is about. And having a single definition helps us to not have every single organization working on its own in isolation to try and invent its own equity agenda. But how do we have a roadmap that's for the province that we can work together and say we have a starting point, not just those pieces of legislation, but this is what health equity is. So I just want to start our symposium today with this definition and reflect on it. Health equity allows people to reach their full health potential and receive high quality care, of course, all those 6 dimensions, that is fair and appropriate to them and their needs, no matter where they live, what they have, or who they are. Very aspirational definition. This was not done in an ivory tower. This was done through consultation. It reflected many people's views, perspective, needs in terms of promoting this agenda, and it is quite aspirational. So as we talk together, I want to think about how do we fulfill this definition? How do we lead with this definition as a starting point? So one of the ways that we think about it at Health Quality Ontario is how do you make health equity not only the right thing to do, but the easy thing to do? How do you make it easy and practical? And that's essentially the tenor of a lot of what I want to talk to you about today. So I'm going to talk about each of the pillars of our work and what we've done quite practically to make sure we don't forget this equity lens when we're thinking about the 6 dimensions. So the first one is this mandate I talked about, which is promoting healthcare that's based on the best available evidence. And so one of those functions is that we actually recommend to the Minister of Health which new health technologies should be funded. These are very expensive technologies most of the time. They may already be approved by Health Canada. It may mean that people who are in desperate need of those technologies are paying out of pocket. There's an immense equity lens that needs to be taken into account when we think about which one of these do we fund, given finite resources. So one of the things that we do is we demand of the evidence, what does this say about health equity? And so we use what's called the Progress Plus Health Equity Framework at Ottawa. And we say, when we assess this evidence, what do we know about the impact that this new technology will have on where people live, who they are, what circumstances they may be in, what out-of-pocket expenses they may be paying. And you can imagine that it's not as if there's a wealth of evidence all the time when we look at these new technologies, but taking that step to say that this is an important part of assessing what gets funded in Ontario means that we're increasingly demanding of manufacturers that this type of evidence is available. That it wasn't that long ago that lived experience wasn't a formal part of evidence for health technology assessment. Now it is. This is by creating this kind of framework, you can push the agenda and say, this is the type of evidence we need about what gets funded. Another aspect of our mandate where we think about equity is the creation of our quality standards program. We just, a couple of weeks ago, released our latest 3 quality standards focused on opioid prescribing for acute pain, chronic pain, and the management of opioid use disorder. Sorry, if you haven't been hearing me, I'll try and speak right into the mic. And as we look at these quality standards, we not only engage people with lived experience in how we articulate what does high quality care look like, we also look at the evidence for the impact of that of what we're going to promote on different types of communities and populations. And as you can see in this slide, the lens that we take is how is promoting and implementing the standard going to actually have an impact on the disparities that we see. The starting point for each of these quality standards is that we see an unacceptable variation in care. That could be geographic, that could be based on where not only where people live, but who they are, the conditions they have, and that we try to take a lens of what type of competencies might be needed for the providers who are delivering this kind of care, whether it's culturally safe, whether it's recognizing historical discrimination that may persist and maintain disparities if we don't address them. So again, a very important lens to our quality standards, which you'll see if you take a look at these, is this equity lens. When we monitor and report on the performance of the health system, very close to the type of work that Alan just described in terms of the socio-demographic data collection, we could declare victory on a number of indicators and say that according to the average, Ontario is doing really well. We've had improvements, we're maintaining a stability, and if we don't look below the average, we could stop there. But if you take something like how many people are overdue for basic preventative care, this is an example of colorectal cancer screening. We can see that although we've gone in 2 decades from 14% of the eligible population being screened, extremely low, to now over 60%. If we don't look at that data and see who's being left behind, we could easily say this is just an improvement and that's good enough. And this is where we work together as Health Quality Ontario, with each of you in this room, where we say locally, you use the data collection that Ellen introduced, and you understand who are those populations in a given geographic area who are not getting this preventative care and why. And what can we do to target what is a life-saving preventative screening, which actually prevents cancer? How do we make sure that the populations who are systematically not receiving that or not benefiting can benefit from targeted programs? The last example I want to give is our Quality Improvement Plan program. And this is part of the Excellent Care for All Act, which means that over 1,000 organizations every year publicly declare what is their quality improvement plan based on data. And for 2 years now, which doesn't seem like a long time, we have been requiring that organizations reflect on how they're going to reduce health inequities in that plan. And how is that integral to quality improvement planning? It's not just quality is over here and equity is a separate stream, but how, through our quality improvement plan, are we going to reduce disparities? And I encourage you to look at our 2 Insights for Quality Improvement reports that took a focus this year and last year on health equity to see what those 1,000 organizations are doing and what they're tackling. And you'll probably see yourselves and the initiatives that you've created in those. And this will increasingly become a part of that quality improvement planning exercise. We start with the narrative section of it. We start with what are people doing, what are the different best practices, and eventually we will get to how is that embedded into how we're reporting on this, how we're targeting interventions that are integral to quality improvement. Okay, so this is a region that, as Camille said, has shown a great deal of leadership in health equity. This is the 5th year of this symposium. There's 25 organizations in this region who have taken up socio-demographic data collection. There are, as I understand it, 80 different organizations in this room who consider it important enough to spend a day focused on working together on health equity. And I want to talk about 5 considerations for how we can work together and collaborate, and to maintain the momentum that's been built up over the last 5 years in this region and many more years in the province. And I want to talk about how do we work together to do justice to the building blocks that are available to us in this province, but more importantly, to honor those we have a responsibility to serve and to reduce the barriers that may be in the way of getting excellent care for all. So a few practical considerations that I hope will stimulate some discussion. The first is that data is an extremely powerful tool, and it can easily get underestimated. It can also get overemphasized. But let's start with the where it is powerful, where it can help us. So we know that quality initiatives that don't explicitly take a focus on reducing disparities can run the risk of having mixed results, not targeting those disparities, not reaching the people who clearly need it the most in terms of a quality improvement, and can sometimes actually widen disparities if you just focus at the average, at the general population. And we know this from the literature. And I like to cite the At-Home Chez Soi initiative, which is the world's largest trial focused on housing first as an intervention. It tracked 2,000 participants over 2 years. It was active in 5 different jurisdictions in Canada. And for many people who have been proponents of housing first, they didn't need this trial to know that this was an intervention that worked. They weren't surprised by the benefits that were shown for the seriously mentally ill. But I have to say, when it came to securing investment for some of our most vulnerable members of our communities, it sure helped to have this kind of formal, rigorous data when it came to policymakers making decisions through the mental health strategy to say this was a trial, this has been shown across Canada, it's pan-Canadian, and it's a lot easier to secure that investment when we have that kind of formal data. It can be frustrating that you need that when it's not the first time this has been demonstrated, but it does show the power of this kind of data and rigor. So beyond research data, which that represents, how do we keep equity elevated as a priority? And that's where routine data collection comes in. For those of you who can see the slide that I'm showing now, this is about the disparities in premature mortality across neighborhood income quintiles in Ontario. This is one of those data points where we could see over the last 2 decades a really fantastic victory for our population in Ontario, which is a steep and dramatic decline for both men and women in terms of potential years of life lost. And this is a public health marvel, right? If we didn't look at neighborhood income or particular populations, we might not see, or we could easily ignore, the fact that this is being disproportionately felt, this benefit, in different communities. And you see it when you look at sub-regional maps, you see it when you look at low-income women versus high-income men, as an example. And you see that this is one of the biggest health outcomes that we as a health system should be tracking. And I think more and more, as we embed this kind of routine stratification and data collection in our reporting, it becomes much more difficult to ignore where we need to target our investments and not just target the average, not just target the general population. So routine data and routine monitoring is much harder to ignore and true for health equity. The third point I just want to bring up is that patients and patient engagement have a really critical role in answering what I think are really basic questions. Why are we collecting this data, and how are we going to use it? And we need to be asking patients themselves, why? What expectations do you have of us when we collect this data? And in particular, I think one of the key innovations of the LHIN and the Mississauga Halton Sociodemographic Data Collection Project is that it's collected at the encounter, it's collected at the point of care, and this is an opportunity. At the same time as it creates an expectation of patients. What are you going to do with this data? If I'm sitting in your office and I give you this data and then we don't discuss it and nothing happens with it, that may create a disappointment. And it may be losing an opportunity to have what may be an immediate referral that may address food insecurity, it may address the need for income supports, that has an impact on your healthcare. And so at the point of care, what expectations are we setting, and how do we work with patients to design what is the protocol we need to have when we collect this data? Similarly, when we use this data, as it gets more mature for population health planning, for quality improvement and monitoring and reporting, what are the patients' expectations? What are our community's expectations for how we're going to use that data, and how do we honor that? Second last is focusing on what's practical. I think everybody in this room this will not be hard, but as you're trying to, for lack of a better term, sell health equity, promote health equity, it can be really important to focus on what's practical. If you think back to the definition that I showed at the beginning, where everyone has the potential to fulfill their health potential, no matter who they are, where they live, that's a highly aspirational, ambitious target to set. If you don't focus on the practical, you can get bogged down by thinking this is complicated, this is huge, this is big, I can't do this alone, my organization doesn't have the money to do this, we'll only scratch the surface. Really important to focus on the practical. How can you make someone's life better today? And you see examples here from the Insights report of translation services that can make a huge difference to can I even participate in the health system, to inclusive care, to training for culturally safe care, and very practical steps, even like at the point of care, how am I using health equity data to support my clients, my patients, caregivers. And so keeping a focus on what's practical can be essentially keeping us away from getting bogged down by what may be too aspirational. And I do want to say that this doesn't mean that we can't dream big. It doesn't mean that something like national pharmacare isn't going to make a huge difference on the population. We think about out-of-pocket expenses. But there's many things we can do locally and practically that can happen today with this data. And the last thing I want to leave before we open it up for conversation is not waiting for the data system to be perfect. We know many, many examples in this region, all around the province, of programs that didn't wait. Didn't wait for legislation, didn't wait to be told, didn't wait till it was mandatory in whatever accountability agreement might be awaiting you. And that sometimes some data is good enough to get started. We know a lot about disparity. There's been a lot of research about disparities. How can we get started and then perhaps create the routine data collection out of a program to continue to demonstrate the needed and continued investment? And I have just one example here of our health equity lead, Dr. Jeff Turnbull's managed alcohol program in Ottawa, started 17 years ago. And I often talk to Jeff about how we need to do a better job of collecting routine data on health equity in Ontario, but I'm always struck by the fact that he and his colleagues and his partners didn't wait for the perfect data system to say, we need something to divert people who are inappropriately getting sent to the ED or to jail or to shelters that don't have the capacity to fulfill their needs, to create a targeted program that is going to not only make their lives better, but also save the system. And so I just want to leave you with not waiting for the data to be perfect, and I'm looking forward to the conversation. Thank you.
Thank you, Anne and Camille, for your pearls of wisdom and knowledge. But don't go anywhere. We have lots of questions. We can try and grill you with some questions here from this. So what I heard very clearly is the importance of and thank you for that comment, because I'm starting to kind of learn about reflection and not representation. I think we need a lot of work to do around representation. We've come a long way, but still a lot of work to do around those vertical structures in our system that need leadership. So thank you for that. And of course, you're wearing the HQ hat, so fantastic work. You guys are leading the projects around that and providing direction and working in partnership at a local, regional, and provincial level. We borrowed heavily your definition of health equity, so thank you for that. And by the way, for those of us who participated in that process, that was actually quite an involved, engaged process to where you got. And with respect, it's malleable and it'll change how it's super exciting, so thank you. And those last two comments about being practical, starting somewhere. I think we get caught up in the dynamic of too heavy or too difficult. That's a problem in our system as well. And don't wait to be perfect, so I like that sentence as well. So with that said, I'm going to start. There are two pre-questions, or two folks that are going to be asking questions, and then I'll open up the floor to other folks to ask questions. So Corey, I believe you have a question for Anna and or Camille.
First, I want to say thank you for for joining us today and for providing that keynote. I really appreciated the messaging I think that you began with as well. Full disclosure, I participated in helping shaping this day, but I do think it is really important to have, as we do these equity symposiums, two black women who are at the senior leadership level in this province in healthcare participating and as that representation for all of us who kind of work in the system and are looking for people who share experiences with us, are like us. So I do commend you for that, although we need to do more of that. And my question, I guess, that I want to ask you is that you spoke about leadership at different levels. So for the folks in the room who are not leading health system agencies at the provincial level, what are some kind of practical, tactical solutions for how we can kind of participate in advancing the equity agenda forward?
I think leadership comes in so many different forms. So if you're employed within an organization, then how do you build equity in your work? By beginning to ask the questions. It doesn't mean you are the decision maker, and you may get stalled in that the person you report to may not move on the agenda. But then, if you have the question, you ask the question, I would suggest that you also find allies within the organization and in other organizations, so you don't necessarily stand out as being a target for being the shit disturber, etc., etc. But if you reach over to another organization and have an ally in another organization, you can begin to move the agenda. The other thing is I believe and support allies, because some of the time, so I'll give you an example. There is a particular group working in a particular organization, and I went in with Samir as the part of the external advisors. And we went to the staff and say, what are the questions you have that you cannot ask because it puts you at risk in your job? And because we could see there were gaps. And so as the external advisors, we then got to ask the question. And we got to push the agenda as the external advisor. So there are just different techniques like that that I think can be used. But I think the allyship across organization to begin to move an agenda is helpful. And the other one is stepping out, because you also have a private life, which means you're also a community person, which means you have a private realm that you can also work to move that agenda forward. So those are the things that I think individuals can take leadership roles in. I do think, and then I'll hand it over, I do think we need to change our definition of leaders. My own personal thing is we should not be calling people at the top leaders where the only thing they lead is their organization. I think we should be redefining leadership at the top, and leadership at the top should be that you are leading with others, you're forming coalition. What's evident here is two organizations leading this symposium. That's not just an internal piece. That is a sector, or putting this on for the entire sector, I think is a leadership role. And continuing to do this, because I'm sure there's not a lot of money in the LHIN or in the agency. So committing scarce resource to a broader agenda for me is a really symbol of leadership. So those are some of the ways that I think people can lead.
I would just add that most of what you see provincially as the frameworks and the building blocks and the foundation for health equity are actually from local grassroots organizing and us, the province, following what organizations have identified as a need have used data to demonstrate and to actually build programs without waiting for permission. So I actually see a huge leadership role in local identification of need and not waiting for permission.
I think I really want to push people here today, including the LHINs, that we need to take a quick look and a long, deep look at our trans and two-spirit communities, and particularly our Black women, trans, and Indigenous communities in their health inequities. So I think that I've been here, this is my 5th symposium. I've been a keynote speaker, I've been a facilitator, I've been an organizer, so I know my folks around the table here very well. And I'm just wondering, Camille, if you could maybe talk to us about how Toronto Central LHIN institutionalized their commitment to health equity and what it needs to do, and would you do it again?
Yes, it meant a lot to me, and I'll do it again. And mainly because it doesn't have to come from a personal level, but it did for me come from a personal level. I was an immigrant. I was a Black woman. I was a gay woman. I have friends who their children are transgender. So I live in a world of intersectionality. And I saw the disparities that exist in all of those. I also saw what I consider the preferred immigrant. So that when we're moving in jobs or we're saying we're diverse, then the recruitment is Asian folks, Indian folks, who are all competent. So that's not my question. My question is that diversity and reflecting community usually stop at bringing that group in, but the Indigenous and Black group are still left out and get the worst health care. Not enough conversations about the intersectionality and who then are even worse off. So while we're doing a lot of transgender work, which is really good work, the Black transgender, the Indigenous transgender, that all of those other isms apply to them as well. So coming from that space, it was personal in a number of ways. But also I just believe in Toronto. I believe in Canada. I believe that this is a great country. And I think we need to do this work to prevent us having some of the same issues that has emerged in London, in Paris, where those systemic issues have been ignored for so long that the next generation is angry. And so that scares me. And so I thought the system needs to begin to pay attention. And one of the ways was, because I was a LHIN, did have some privilege of trying to push this out to make it mandatory. As I said, received some success, a lot of players bought in, but not everyone. And so it became an uphill battle. And I see that battle continuing, and there's movement there. So me personally now is moving out on the outside, working with the community, for the community to begin to demand. And I think we will have success at those two groups moving the agenda at the same time.
So we're taking one more question. So, oh my God! So, Liebe, you started off standing up, so we'll let you finish.
Thank you. Thank you for organizing this event. My name is Liban Gabriel. I'm from an organization called Tribal Community Health Center, and it's good to see, as it was said early on, two Black women setting the stage for the Health Equity Symposium. Something I didn't hear in the first part of this morning, or a word or a term that I haven't heard, is racism, discrimination, or anti-Black racism. And I'm wondering whether we can talk about equity in healthcare without talking about or bringing to the forefront racism, anti-Black racism, and discrimination.
Thank you, Lieben. I thought I would wait for somebody else to introduce that, so I didn't come across as the angry Black woman. when I talk about Black and Indigenous being at the bottom of the pile, we are at the bottom of the pile because of anti-Black racism. It is because bias exists and we all have it. We don't always recognize it. In the US, as horrible as we may think of the US, when I walk into the US, man, I know exactly where everybody stands. Right? And they say what they think. I know it. I can navigate it. I've been in Canada. I've been in healthcare for 50-odd years. Until recently, I was in a room where I was the only Black CEO and stuff. It's hell. Because it's lovely. We have codes where we speak and do things. But it's evident. I know it. I go to a table. There are a few of us around the table. You experience it. So finally, we had to mobilize and get the work done. The one thing I will also identify is that as I talk about anti-Black racism, I do that in partnership with my Indigenous colleagues, but I'm very clear that I do equity work, immigrant work, refugee work, very clear that the Indigenous population is not part of that. The Indigenous population were the first people here. We're settlers. We, though, form partnership with them because we see the injustice. And when we talk about life expectancy, you need to really look at the life expectancy of the Indigenous population, and it is an embarrassment. And so how do we then get some of that work done? But yes, it really stems from that place of the anti-Black racism. And that's what it is, and we're finally calling it out. But the people who suffers the most from that are the Black and the Indigenous population. And that is not just white people. That is intersectional. It happens within all the immigrants as well, all the classes as well. I see a lot of my brown colleagues agreeing with me because it makes a difference. The lighter you are is the more acceptable you are, and the more easily you're welcomed in. And so we need to call that out and do that. I look across and I see a whole bunch of Black and Indigenous people hitting middle management. They ain't going much further.
I would just add that we have the privilege of ignoring this because it's anecdotal. And we see emerging with the socio-demographic data collection. I've heard, I haven't seen it published yet, use of mental health restraints being used differently with different populations. We hear about that. We hear about care being different. But I think until we can have that data, and that's unfortunate, I know many people in this room would say, I don't need the data to know. But I think that's what's going to formalize this. That's what's going to make it much less hard, much harder to ignore.
My grandson is a nurse at a mental health hospital emerge department. And we are sitting around, hanging around, and my grandson is a little Filipino kid, right? His mother is Filipina. He's a nurse. And he will say, I can tell you, based on the staff in the emerge department, the degree to which restraint will be used this weekend. And so I said, what do you mean? He said, Black man walk into emerge, if he's agitated, he's being restrained. And that's just it. And so the people who work in the system knows it. They don't yet collect the data. And then I know the hospital now have the data, but it's not making it public. So even when we begin to get the data, our next thing is we need to see the use of the data. We also need to be a participant. So the other thing I would like to say about data is the extent to which you can get an advisory group to look at your data before you use it or publish it, it's important. And it's important because the Indigenous people have said it, the LGBTQ community is beginning to say it, Black, nothing about us without us. And I'll give you an example of why it's important. There's a bunch of data that was just collected recently, and megadata. Everybody's now talking about megadata, but biases are built into the megadata. So the megadata says, in this community, there is more criminal activity than any other, so therefore this community should have more policing than this other community. That's what the data said. But the context is missing. And the context is, in this community, there's more policing and carding, which goes into the data than this other community. So the act of policing actually now generate the data that said there's more criminal activity. Somebody who don't know that doesn't put that context in. And suddenly the data is telling a different story than the actual story. So for me, that's the next round of the data collection, is how do you get people outside of the system who's collecting the data to look at the data and review the data and put a context around the data, and then we use the data. But this whole notion of nothing about us without us is the whole bunch of us are organizing about that, because we're supporting the data collection, as you know, but we want to build this other piece into the equation as well.
Okay, I think that takes us into a break. Thank you so much, Anna and Camille. You're going to hang around, so you have lots of questions. Camille, apologies for